Welcome, everyone. We are here at the Research Ethics and Policy Series. Thank you for those of us who are here in person in the room, and hi to everybody who is joining us online. My name is Holly Fernandez Lynch. I'm an assistant professor in the Department of Medical Ethics and Health Policy. I'm the REPS co-chair along with our department chair, Steve Jaffe. And today we are very excited to welcome Dr. Rita Redberg. We had a couple of COVID and other related cancellations and moving things around, so we're glad that it's worked out to have you here today. Dr. Redberg is going to be discussing ethical issues that arise in balancing safety, innovation, and access in medical device regulation. And I'll say a few more words of introduction in just a moment, but we have a couple of housekeeping announcements to go through first. So we are recording this session and we will post the video to the department's website when that becomes available. This is our last session of 2022, so we'll see you again in January with one very important change, which is that we're moving from first Mondays to second Wednesdays. We'll still be at noon. And then the first session in January, we'll hear from Dom Sisti from our department, who will be talking on ethical issues in psychedelic research. That's January 11th. So as we continue to add to our list of potential speakers, we would love to hear from you if there's anybody that you think would be good for us to invite. We should also state that we'd be especially grateful for suggestions for speakers from diverse backgrounds or who would contribute diverse perspectives to issues related to research ethics and policy. Here is a quick reminder about some online resources from our department. We have several short research ethics courses available for free continuing education credit. Some of these are also available to satisfy the research ethics training requirements imposed by Penn or CHOP. Just let me know if you have any trouble navigating that. I've recently got a little bit of pushback from the IRB myself on this, so happy to navigate if it becomes an issue. And then finally, thanks, of course, to our REPS co-sponsors who are shown here, and a special thanks to Mary Pham, who has helped administer REPS since its inception a couple of years ago and has recently received a very well-deserved promotion within our department. Thankfully, we will get to keep Mary around, but I wanted to take a moment to recognize Mary for her really critical contributions, making this series look so effortless, making sure the trains are running on time, our speakers get here, we have food. So thank you. And thanks in advance for helping make sure that your successor will be all up to speed and we have a smooth transition. So with that, I will briefly introduce Dr. Redberg, who is a cardiologist and professor of medicine at the University of California, San Francisco, as well as an alumnus of the University of Pennsylvania Medical School. For more than a decade, Dr. Redberg has served as the chief editor of JAMA Internal Medicine, where she spearheaded the journal's focus on healthcare reform and less is more medicine. Her research interests are in the area of health policy and technology assessment, how to promote high-value care, focusing on high-risk medical devices, as well as the need for inclusion of women in clinical trials of such devices. Dr. Redberg served on the Medicare Payment Advisory Commission, which advises Congress on Medicare payment issues, and also chaired the Medicare Evidence Development and Coverage Advisory Committee. She has given congressional testimony multiple times in hearings related to the issue of balancing safety and innovation in medical device approvals, and we are very excited to hear more on that topic today. So I will invite you to join me at the podium, and then very briefly, since we have folks who are in person and online, when Dr. Redberg is finished with the lecture, we'll alternate for the Q&A. You can put your questions in the chat on Zoom whenever they come to mind, but we will save those until the end. Okay, please take it away.
Thanks very much, Holly and Steve, and those in the room and online. It's always great to be back at Penn. I have very fond memories, and I'm happy to come here anytime. And it's really was at Penn and with John Eisenberg when he was chief of general medicine here when I was a medical student and planning to be a general internist, that I got really interested in the idea of how does evidence inform medical practice, and realized that we didn't actually have medical evidence underpinning a lot of things that I was doing every day. And it really kind of changed my whole focus on my career. And I did end up spending a year between my third and fourth year of medical school doing a master's in health policy at the London School of Economics, courtesy of the Turon Fellowship, which is a great Penn program exchange between University of Pennsylvania students and Great Britain. And actually, so it was a very interesting experience to see another system, and certainly and to study health policy, but also to see a capitated system that spends really less than half that we do per capita. Yet, I mean, at that time, 1981, I got an NHS card as a student, and certainly now I don't think they give it to foreign students anymore, but every British UK citizen has health coverage, which is more than we can say in the United States, even though we spend a lot more. And so I'm going to talk about accelerated approvals, but that is kind of how I got interested in the whole idea of technology assessment, because when you start looking at why do we spend so much on healthcare and yet have such uneven results in the US, I think technology is the low-hanging fruit. So today I'm going to talk about the sort of ethical use of novel drugs and medical devices approved with incomplete evidence. And really, I think the whole question is around that balance of novel and what is novel and innovative, and and safety. And I was at a cardiology clinical trial meeting last week where there were a lot of people from FDA and industry talking about approach to novel devices. And I think, it sounds good when you call it novel. If you substitute dangerous devices, it sounds very different. And sometimes it's very unclear at the point, because there's such incomplete evidence, whether we're talking about novel or dangerous. And so just to keep that in mind, and I am going to talk about drugs and devices. My real focus is on devices, because I think as when I started working on it, someone said to me, it's really the Wild West of medicine. And I think it's kind of still the Wild West of medicine in terms of regulation. My funding is from Arnold Ventures and the Greenwald Foundation for this work. So I'm going to talk a bit about the expedited approval process and how it compares to the usual approval process for drugs and devices in a very top line overview, because that you could easily spend hours on. And then a little bit more about what do patients and physicians understand about expedited approvals. I'm also going to include some other ethical issues, like the issue of sham or placebo control, and actually when I think they're appropriate. And then a little bit about the work we did, a Delphi panel looking at the ethics of accelerated approvals that Holly volunteered to be part of, which was great. So expedited pathways is certainly, I think, something that we hear a lot more about lately, and for good reason, because there's a lot more focus on expedited pathways, and there are a lot more expedited pathways, and a lot more drugs and devices are getting to market based on expedited pathways. And there's a number of different pathways. There it is. So, and just to mention, are you all, and I can only look in the room, familiar with these pathways already? I see a lot of yes and no. So I'll just, the slide is a summary, and I think you have my slides, so you're welcome to distribute them. But it's really, I just put it up here, not so much so that we can go through each one individually, but to show that there is a lot of attempt, and the same is true on the device side, to have different ways of getting promising new therapies to market more quickly. And generally, they have some criteria. And I think one of the issues is how broadly or narrowly you define the criteria. And I'll talk a little bit about that, but they're generally supposed to be for serious and life-threatening conditions. And then the idea is that they get approved on the basis of more uncertain evidence, or, for example, phase 2 trials for fast-track drugs, or often based on surrogate endpoints. So surrogate being endpoints that are supposed to reflect things that a patient actually feels, but don't actually. And in theory, it's a good idea, but in practice, most surrogate endpoints have not been validated. So it's not clear that they actually do reflect things of meaningful clinical benefit. And I think that's a really key point, because I mean, having a patient take a drug or have a device implanted on the basis of changing a laboratory value or an imaging test that will never improve their quality of life or help them to live longer, I think is not really a value-laden proposition for the patient. And that's really what we're talking about if we're improving drugs and devices on the basis of surrogate endpoints that have not been validated. And that's not a topic that gets a lot of discussion, and I don't think is in most of informed consent forums. So certainly one of the ethical issues. The priority review pathways. Should I stay near the mic? I can, or it's okay, I can walk away. Good. So they generally have the features, besides being getting to market on more uncertain and surrogate evidence, they have more contact with FDA. So you get assigned review officers, you get meetings with FDA earlier in the process, and certainly what was emphasized, as I said, at the conference that I was at last week with a lot of industry people there, was how readily available FDA staff were at all stages in order to talk about how things were going in their gathering data on the way to this fast track approvals. And then the breakthrough therapy is the one I think we can particularly hear about. And the definition for a breakthrough is it's something to treat a serious and condition and hopefully a substantial improvement. But again, it can use surrogate endpoints. And so this slide just shows that the percent of novel drugs that are using at least one expedited pathway is pretty substantial in the last few years, which, as you can see, it's well over half of all drugs are using at least one expedited pathway. And some drugs can be using more than one pathway. So I'll show you. And so this is a summary from the CEDAR, so the Center for Drug Evaluation report of the drugs, and you can see that about 36% used fast track, 74%, so 3/4 of drugs that are getting to market used one or more of the expedited programs. Priority review was 34 out of the 50, and breakthrough 14, and same for accelerated approval. So these pathways are being used more commonly, and the same is true on the device side. So I'll just go through, and I was going to start with sort of the categories, because device approvals for many different reasons are different than drug approval. You know, in general, the standard for drug approval used to be, although not so much anymore, particularly with the use of so many additional pathways and fast track pathways, but it used to be 2 randomized controlled trials with the idea that, you know, the results in one trial could be a quirk, but 2 trials would be very reassuring, of reasonable size and with clinical endpoints. For devices, first of all, devices came to FDA regulation much later than drugs did. Devices were not regulated until 1976, and really it was after, as often happens, a big problem with IUD implants and the copper, where women, and a lot of the problems happen to be with women's reproductive health implants. But it was in 1976, due to the IUD problems, that the FDA introduced or was governed by the Medical Devices Amendment. And at that time, there were already a lot of devices on the market. So some of the quirks of the FDA device approval system is because there were already devices on the market. So they first of all said all low-risk devices, class 1, are exempt and do not need to have any kind of FDA approval studies or anything. They were just exempt from that. Class 2 is moderate risk. And moderate risk is a very big category. And I will tell you, there was some, you know, it's thought, I think thermometers, insulin pumps are in moderate risk, but there were also some heart valves that are in moderate risk. And in fact, the Impella. Are you familiar with Impella, mechanical circulatory support? It's very common in cardiology, and I'm going to use it as an example in a little later. But it's basically, it's a huge support. It's a left ventricular assist device. It gets placed through a very big incision in your groin, goes up into your heart. There's nothing moderate risk about it, but it was initially entered market through a moderate risk pathway. But the idea of the 510K was initially that a lot of devices would be in the 510K until the FDA could sort out which was actually moderate risk and which was high risk. But that, I think the FDA became kind of overwhelmed with the number of devices in 510K because there were clearly a number of high-risk devices that were supposed to be moved out and that have remained in class 2 for many years. Yes.
Does the moderate risk refer to the risk of the device or the risk that it's not substantially equivalent?
The moderate risk refers to the risk of the device. So the substantially equivalent is actually the way you get the criteria for clearance. And so the 510K is called a clearance because there are no clinical studies required. It's not considered an approval. The FDA clears your device for market. Substantially equivalent means that your device was deemed to be substantially equivalent to one that is already on the market. And that's the 510K. So most devices that you see are in the 510K pathway. In the last few years, I think in 2015, the FDA actually introduced another category for class 2 or moderate risk, which is called de novo. And the de novo pathway is for new moderate risk devices. And for the, as I said, for this pathway, there's no clinical data required. I actually thought you might be asking about the risk if things go wrong, because the other problem is you can have a device that's called moderate risk, but still if it goes wrong, like an insulin pump, it can result in death. I mean, a lot of things, when they, particularly devices, which more often tend to be implanted, when they go wrong, metal on metal hips, they can result in death. And so there's a debate over whether the risk classification should be according to the insertion of the device, the disease it's treating, or what the potential downside of the device is, which could be very serious. And I am editor of JAMA Internal Medicine, and we published a study, probably 8 or 9 years ago by now, from Diana Zuckerman and Steve Nissen, where they looked at adverse events and the class of device that was associated with the highest risk adverse event reporting. And it turned out that most serious adverse events, including death, are associated with class 2 devices. So again, showing that you can be a moderate risk device, but still be associated with serious or adverse events. Okay. And then the least common and most rigorous category for medical devices is the high risk category, or class 3. And that's the one that goes through the pre-market approval and does require clinical data. And that was the one that I first started looking at back in about 15 years ago with Sanket Dhruva, who at that time was a medical student at UCSF and then a resident, and now is on our faculty. But we had some interesting findings. I will say, to summarize, what we found was that the quality of evidence that supported these high-risk devices was, in general, not randomized controlled trials, very rarely blinded, and I'm going to specifically talk about blinding in a few minutes. And most commonly, 2/3 of the devices only had one trial that supported FDA approval, as opposed to what had been the standard for drugs, which was 2 trials. Now, what the companies say is that devices are different than drugs, obviously, and that they need to iterate a lot and do changes. And so it's not reasonable to have to go through the same kind of long process that drugs have to go through. On the flip side, of course, if you have an implanted device, we also found that the average study for a pre-market approval cardiovascular device was 6 months long, but most of the devices are implanted. So obviously, if you have an implanted device, it's going to be in you forever unless you go through a risky removal process. And so it's certainly important to have long-term data, and that's what I'll talk a little bit about post-marketing as well. And currently about 5% estimated of all device approvals are through the class 3 or pre-market pathway. And so again, just like for drugs, there are multiple different fast track pathways for devices, although it started out just like in drugs as priority review. Then in 2015, the Expedited Access Program was added with similar criteria as it was for drugs. And then most recently in the 21st Century Cures Act. Are you familiar with the 21st Century Cures Act? Okay, great. The Breakthrough Devices Program was added. And just as a reminder, the 21st Century Cures Act underlines, as I have here, that the Secretary of Health and Human Services should use least burdensome approach. And that's something that I hear a lot when talking to FDA and to industry about the standards for evidence for device approvals, is that the law requires the least burdensome approach. And so again, it's a balance of least burdensome and still assuring safety and effectiveness. And in particular, the breakthrough devices definition in the 21st Century Cures Act says that a breakthrough device should provide for more effective treatment or diagnosis of life-threatening or irreversibly debilitating human disease or conditions. And then it should also have one of these other characteristics. For example, the availability of which is in the best interest of patients. So I would say that it's a fairly loose definition. I think it's not exactly defined. I think most sponsors believe that their device is, of course, for the most effective treatment of life-threatening conditions.
Sorry, can you just explain, would it be possible for a 510K device to offer a significant advantage? Are you getting to that?
Yeah.
You are, okay, sorry.
I am. Yeah, but that is just why I wanted to have the definition up there. Yeah, Kevin.
Rita, is there any consensus on how significant advantage is defined? Like what's a minimum threshold for being considered significant?
No, there is not. And that's, we've looked at the breakthrough devices to try to, figure out by looking at them whether there was a criteria, because there's nothing published more than this. And in conversations with FDA staff, there's no more guidance they can offer than this. So it seems to be, at least to my, study of it, and if anyone has more information, I'd love to hear it, very much a sort of one-on-one negotiated agreement without strict criteria. And if you look at the devices that are designated as breakthrough, there is a wide variety of devices. So this is from the guidance for the FDA, and it specifies that for the breakthrough designation, the FDA will accept a greater amount of uncertainty. And of course, the idea is that you have more greater uncertainty because you are potentially going to be treating a life-threatening disease. But again, there is no sort of, I think any disease could be life-threatening, and there isn't sort of criteria for narrowing that down. And there also isn't ways to define uncertainty or how the uncertainty will be resolved, although there is a point where it says that there will be more gathering post-market evidence. So, but it says the uncertainty should be balanced by other factors such as probable benefits for the patient to have earlier access. And particularly when no alternative treatments are available. Although I will say, looking at the breakthrough devices, a lot are for diseases where there are alternative treatments available. So I think, again, it's a very broadly or widely loosely interpretive definition. And that here's the post-market reference, that there should be adequate post-market controls, meaning that there will be post-market data gathering. This was that's Samket, the colleague I mentioned. We wrote an op-ed in the New York Times just before the passage of the 21st Century Cures Act, which I think was one of the last pieces of legislation that Obama signed. But we had a lot of concerns about lowering what was already, in my opinion, a very low evidence bar for approval of devices, which again are implanted and not easy to remove. As unlike a drug, which when you find out a drug is dangerous, you can stop taking it. That doesn't apply for devices. And we pointed out that breakthrough was defined very loosely, creating a perverse incentive for manufacturers to use this term to take advantage of a faster process to get to market because it's a breakthrough, but also as a marketing gimmick. And so it turns out, and Aaron Kesselheim has done some nice work showing that breakthrough to patients sounds like this is something that perhaps is more rigorously tested. And now we know that this is really something new, exciting, and effective. And actually, it's called breakthrough on the promise of being more effective, but not on the certainty of being more effective. And that is not something that's clearly explained to patients or to physicians. So again, just like the drugs, the number of devices that are going through breakthrough on the breakthrough pathway has increased exponentially. The 22 data is only half the year, so it will certainly exceed the 2021 data. But you can see since the inception of the program, so this was the FDA report from June 30th of this year, you can see that 206 devices got the breakthrough designation last year, and I'm on track to exceed that. And so that means that they will now be able to reach market with less data or more uncertain data. And all of the other advantages, the review accessibility and more review. So this was a paper that was published in Nature Biotechnology that summarized what was the early experience. And it's a very interesting paper. It does sort of summarize and give case examples of some of the devices that were given the breakthrough designation and what happened with them. Again, as you can see, it found the rapid growth of these devices. These were the designations. And by 2020, the FDA had approved or cleared 15 breakthrough devices. And I actually looked, by 2022, the FDA has cleared or approved 56 devices through the breakthrough program, and 16 of those are 510K clearances. So that means at the same time that a device cleared market by saying it was substantially equivalent to something already on the market, it also got a breakthrough designation as being something new and promising and for which there was no alternative, which seems like a bit of a contradiction. This was from the paper, and I just gave you the more updated data than that. This was through 2020. At that time, 7 of the 13, there were 15 devices approved, but only 13 had publicly available information. And of those 7 were PMAs and 4 were clear through the 510K. But as I just told you, it's now up to 16. And that the rationale for the breakthrough designation was only available or publicly written in 7 of the 13 devices. And sometimes even when it's written, it just says this is, for a life-threatening disease without a lot of detail. One example is the Zephyr endobronchial valve system, which received FDA approval through breakthrough in 2018, even though the pre-market study showed a higher rate of adverse events. So what the FDA did when they approved it was call for more post-market evaluation. However, this device has been marketed since 2003 in Europe, but with a very high rate of adverse events being reported in Europe, where they have a different system of CE mark. but that data was not shared with FDA or used for the pre-approval process. So these authors just point out that there are opportunities in the accelerated or breakthrough device program to really gather more data, and that we could, for example, collaborate or use more of the data from other countries where these devices may have been available. This one, as I said, had a lot of adverse events. So just to summarize, the past several years have seen a lot more of expedited approval pathways and breakthrough devices, both for drugs and for devices. And what that means is that we're seeing shorter trials, we're seeing smaller trials. They may not include the hallmarks of rigor, like there may not be randomized, controlled, and blinded. And they are more often going to use surrogate endpoints, which again, really, it matters whether or not those surrogate endpoints have been validated or not. And they're being increasingly used, as I've showed you. So, I mean, we can talk more, I think, in Q&A about the ethical implications, but certainly some of them is that patients and physicians are often unaware that drugs or devices have gone through breakthrough, right? It's not something that would be immediately apparent to you. And so when you're prescribing or using a breakthrough drug or device, you aren't aware as a doctor or as a patient that it means that the trials were shorter or had more uncertain endpoints or more surrogate endpoints. And so that information, I think, could be better transmitted to patients for sure. I said I wanted to talk just for a few minutes about the use of sham controls. And this was a perspective I wrote in the New England Journal in 2014. And I would say now I would just call them placebo controls, mostly because sham has a negative connotation, and it really is that placebo is sham. And I'll tell you why I thought about that. But only 1%, well, at this time it was 1%, I think it's maybe up to 5% now of medical devices get through the market through pre-market approval. And those are the only ones that, as I said, require clinical data. But it was still, when we looked, Samket and I looked at the quality of evidence for devices, a very low percentage, I think it was about 10%, are blinded studies, and particularly not double blind. So as an example, I'm a cardiologist, but I think everyone is familiar with stents, right? The mesh tubes that can open a coronary artery. So, for years, starting really back in the 90s, since stents did not enter the market based on randomized control trial. It was registry data, and happy to get into it, but the bottom line is there were no randomized control trials ever before reaching market. When the studies were done of stents versus medical therapy, and the first one I think that got a lot of attention was Courage back in 2007, it showed that people did just as well if they got medical therapy than if they got a stent for stable angina. And they didn't have any less heart attacks with the stent. They didn't live longer. But there was, in the Courage study, a transient benefit on symptoms, angina or chest pain, that was seen in the first year, started to disappear by 3 years, and was gone by the end of the trial at 5 years, so there was no difference. But that, like every other study of stents, was not a blinded trial. You were either taken to the lab, and if you've ever heard the consent form, we can fix your artery, we can open it, you see the pictures of the narrowing and then the open artery with the mesh. And so there's a lot of placebo effect. There's a lot of placebo effect anyway with procedures. And so I was trying to stand up at cardiology meetings and argue for a placebo-controlled stent trial. And this did not gain a lot of traction, particularly among my interventional cardiology colleagues, who one of them told me that he was at the Society for Cardiac Angiography and Intervention meeting, and that they had the top 10 threats to interventional cardiology, and I was on the list. But I just thought it was important when you're looking at a subjective endpoint like chest pain, that you have a placebo control. And they said, no, it would be unethical to do a placebo control. But then the Orbita study happened, not in this country, but in Britain. And how many of you have heard of the Orbita study? I see some hands. Great. Actually, that the PI for that study was at this meeting last week. I have great admiration for her. But the Orbita study was done in Britain at Imperial College. Rasha Alamid was the PI, and it was led by a group of interventional cardiologists who fully expected to show stents were better. But what they did was actually do placebo control. So everybody went to the cath lab. Everybody thought they got a stent. Everyone got instrumented, but only half of the group got stents. The other group just went to the cath lab and got instrumented, but nothing. And in order to be in this study, you had to have severe coronary artery disease. And what they found was absolutely no difference between medical management and stenting, not even on symptoms. So chest pain got better to the same degree, whether you thought you got a stent or you actually got a stent, which is what I had suspected all along, because, atherosclerosis is a generalized process, right? There's no reason putting a little mesh in one part of someone's artery is going to change the entire, generalized atherosclerosis. And we have very effective medical treatment. However, the problem is, and I'm spending a few minutes on it because it's an example to me of the problem with device approvals, is that once something gets established, it's very hard to reverse practice and culture and guidelines. We have a fee-for-service system. We get paid much more to put stents in than we do to do medical therapy. And, at this point, stents or angioplasty started really when I was doing my fellowship in the mid to late 80s. At the point Courage came out in 2016, which came out in Lancet, it was a very well-established specialty. I don't have to tell you. And it's very hard to stop this speeding train that has, long left the station. And that's why I really think looking closely at what are the standards that let devices get onto market is really important, like the Breakthrough Device Program, because even, there are now multiple randomized trials after Orbita ischemia came out, which, again showed that there was absolutely no benefit to stents compared to medical therapy for all kinds of coronary disease. But yet it's very hard to get people not to feel that there is an advantage to stents, even though they can't show it in clinical trials. Back to the sham controls, it has been done in some examples, like craniotomy for Parkinson's disease was done in a sham control, because the argument was it's unethical to do a fake procedure on someone. But yet, think about it, if you don't do the sham control, then you're doing essentially a fake procedure on everyone because you think it works, but it's actually because you've taken someone and done a procedure and said they feel better. The same for vertebroplasty. The treatment for back pain was done, again, not in the US, but in Australia. They did a randomized controlled trial where half the people thought they got a kyphoplasty, the other half vertebroplasty, the other half got it. They had the same pain relief. And so I think it's really important, and I would argue it's unethical not to do a placebo control for a device trial. But that is still the argument. I would say Rob Califf said in his last round as FDA commissioner, and now he's back, when asked about sham controls for placebo trials, said, well, do you want the truth or not? I think, underlying. So finally, I'll just mention, so our work, so we were very interested in sort of understanding a little bit more and trying to get to solutions to how do you try to still protect patients and ensure informed consent for the changing dynamics of the breakthrough programs for drugs and devices. And so we put together panels of 12 national leaders in medicine and ethics, and we thank Holly for participating. We did 1-hour interviews, and then we also had these same experts participate in Delphi panels, and we kind of talked through the issues of accelerated approvals and what we could do to make the process better. And so these are just, these were my colleagues. It was, again, Sanket Dhruva, Jonathan Jarrow, who, like Aaron's an MD, JD, Aaron Kesselheim, and Jonathan is a JD who's now going and applying to medical school, and myself. And this was some of our results that we published in JAMA this year. But what people said was that people think that if the drug or device is on the market, that it must be effective. And it's very hard to make that distinction. There's no like big black box that says breakthrough drug or device. And so some of the solutions that the experts suggested were that what we agreed on, and then the solution. So we agree that there was a lack of training and regulatory pathways. So there is not, certainly when I was in medical school, and I think currently there's not really teaching in medical device or medical drug regulation. I certainly, even as a cardiologist, had no idea what it took to get a device onto the market. And that physicians are not going to on their own go back and pull out drug and device approvals, not routinely, unless you that's your particular passion or research interest. So that most people are, as I said, unaware of the limitations. And then also, and the last thing is that most physicians tend to learn about new drugs through conferences. These are also CME industry sponsored conferences, publications, industry detailing, and their colleagues. Most people felt that the informed consent process was really at the bare minimum, and that in order to really inform people, you needed to have a much more detailed consent process, and that it needed to cover the differences in the quality and quantity of evidence for breakthrough drugs and devices. And that it should include information about what approval pathway the drug or device went through, and of course it would have to include what that meant actually. And people said things like, for accelerated approval, there's no clear clinical benefit because it's based on a surrogate endpoint, and that it would be important for patients to understand that, but it's not something we routinely explain now. And so these were just some of the suggestions. Informed consent should be vary based on how much evidence there is currently, and that there were concerns expressed that the current system, because of the lack of information for patients, compromises patient autonomy. Suggestions to, use more plain language in consent forms, and there was consideration of a checklist. And the next slide is just an example. Eshor was another contraceptive device that had a very bad history, caused lots of problems. If you have not seen The Bleeding Edge, it's a Netflix documentary about medical devices. I think it's very interesting, but it tells a lot of the Eshor story. But anyway, this was the checklist that was briefly introduced. Eshor was recalled from the market shortly after the Bleeding Edge came out. Okay, so now this was the structure of the Delphi process that I mentioned that we did in addition to the interviews. It was a standard Delphi process where people really spent a lot of time thinking and discussing various solutions, and then we came down to the top 4. And so that is, I think my last slide is our top 4 kind of ways to improve the information and informed consent and about breakthrough drugs and devices. So first we thought strengthening the FDA post-approval study requirements, which I think Holly and others are working on, would be really important, because currently it's estimated that only 30 to 40% of all post-market studies are actually completed on time. Many are never even started, and many more are started but not completed. And then of the ones that are completed, they're not often acted upon. Our experts also suggested informing patients about the risks and benefits, about the evidence through information boxes, like drug fact boxes and device fact boxes. It was suggested that prices for breakthrough drugs and devices should be limited because if they were based on surrogate, and so if you're going to apply the value proposition, there's less value to improving a surrogate endpoint than a clinical endpoint. And it was also suggested, as I mentioned, that we should be improving health profession education about FDA regulation, which I think would be really important and helpful in trying to propose a course at UCSF for our medical students, nursing students, pharmacy and dental students about regulation. So I think this was the summary of the survey. And I just will also thank, as I already mentioned, my collaborators. And I think that is it. So I hope to hear questions and discussion. Thanks very much.
Yeah, Mary. Mary and then Jen.
Was the 21st Century Cures Act sort of the regulatory scheme that started allowing the FDA to accept user fees from the companies that are, seeking approval? Or has that always been the case? And, because like hearing that, it just feels like that's priming the FDA for regulatory capture when so much of their budget, like almost 50%, is from these user fees from companies.
That's a great question. And no, medical device user fees and drug user fees, so PDUFA and MDUFA, have been around before 21st Century Cures. But you're certainly right, Mary, that so the drug user fees and device user fees were, and maybe someone else who knows more about this than I do wants to add to it, but they were a way to get more money, resources to the FDA, and specifically by levying fees for drug applications and device applications, but they were specifically tied, or at least this is how it's played out. I don't know if it had to be that way, but they're specifically tied to speeding pre-market approval. And so because they just renegotiated the MDUFA and PDUFA, there was, I think, an attempt by FDA to talk about post-marketing resources, because I will tell you that the post-marketing surveillance at FDA is extremely under-resourced. Currently only 5 to 7% is estimated, or somewhere between 5 and 15% of all adverse events get reported. And they get the only required reporting is by industry. And so patients and physicians are not required to report adverse events. The ones that do will generally report to the company, and then the company decides whether or not to report to the FDA. And so what was certainly shown in the bleeding edge, and I suspect was not an isolated occurrence, is that tens of thousands of adverse event reports get to the company. Very few of them get to the FDA. And then the other thing that we actually studied was how the company then also classifies the reports according to whether they're a malfunction, injury, or death. And in a study that we did with one of our trainees, who's now a cardiology fellow, Christina Lalani, we found that 35% of deaths in people with medical devices that were reported in categories other than death, like malfunction or injury, which is important because only deaths are routinely reviewed because there's so few reviewers at FDA. They just don't have the staff to regularly be going through adverse events, although that, of course, would be, I think, in patients' interest, because that's how you would identify safety signals. So in the last negotiations, which are all closed door, but what I heard was a bit closed door between FDA and industry. So just the access is, there's no closed door between patients and the FDA, even though the rest of FDA money is coming from taxpayers, patients don't, or clinicians don't have the same access. But in those closed door negotiations, what was reported is that FDA tried to add more resources for post-marketing, but that was vetoed by industry, and I don't think it made it into the legislation, but maybe someone else in the room knows more about MDUFA or PDUFA.
Jenny?
So it seems like one of the challenges in studying devices is that even though we can get frequency of adverse, even if it's understated, frequency of adverse events, we actually have no sense, unlike with drugs, the denominator, like the number of devices. And I wonder if you had any ideas for how researchers can get around that, deal with it, or, surely it requires some other systemic changes, but aside from that, what you might suggest for studying actual frequency of adverse events.
Right, so it's a great question about, that's always the criticism of using the adverse event data is that you don't have the denominator. And it's not easy to get the denominator because it's all, theoretically you could get it if you knew how many devices the company sold, but they don't release that data, they don't make it available, and they're not required to. For some things, if it happens that there's only one ICD-9 code for that particular device insertion, like they get their own code, you might be able to get it that way. What I can say, and actually after the bleeding edge that I mentioned, I was interviewed for it, and so was Madrice Thomas, who runs this device events company, and she used to work at FDA. And device events is a clear company, and it takes Maud and kind of puts it into just a more user-friendly format. It's just a lot easier to search on. And what she reminds me constantly is that for all its limitations, Maud is still the #1 source for any safety signal. For recalls, withdrawals, they all come from Maud. And so, we keep looking. It's always the reviewers' criticism, well, you didn't have denominators, we try to get sales data. It doesn't, it's like, well, there's no harm because we're not looking. It doesn't seem quite right to say, the device isn't harmful because the data is all being held in secret to give you the actual percentages. What we can look and see that adverse events are going up. For example, we just, we're looking at some cardiac devices like CardioMEMS, and you can see clearly, numbers going up, but then reviewers say, well, you don't know, cells are, implantations are going up, people are reporting more. That could all be true, but the concerning part to me is, the adverse events are going up. I'd love to have all the rest of the data, but it is proprietary and hard to get. As I said, though, I still think that is the most important data for patient safety that we have. I'd love to see transparency and more data available there. And okay, we can work together on that.
We're going to go to online here. We have a question from
great.
Louise Russell.
Hi, thank you, Dr. Redberg, for your talk. I guess it's a question. It seems to me there's a contradiction in the fact that so often the solution that's offered for the problems that you've outlined is to inform patients of the risks and benefits and to educate physicians more about risks and benefits and about the regulatory process. And yet, as you've told us, there's very little information about those risks and benefits and very little to know because very little information is required for approval. Post-marketing studies aren't completed. It seems to me that the solution can't be to inform patients because there's no information.
Do you have another idea?
No,
Yeah.
well, when you talked about the European studies, I thought, what if somebody created a central repository of information from all over the world? And what if somebody, and when you talked about the adverse events that were reported to companies, but not to the FDA, what if somebody created a voluntary system for people reporting to a voluntary organization, not the FDA, not the companies, so that we could begin to gather this information outside of this whole process, which seems, I'm an economist, and it's well known among economists that regulatory processes tend to be captured by the people who are regulated because they're the ones that care most. And this process has definitely been captured. Is there some way to create a sort of an outside organization, perhaps an international outside organization that could collect all this data and make it more readily available?
So that's an interesting idea. I've been we've been thinking about trying to work on actually an app, like a MedWatcher app, because right now, assuming that people really want to report more, it's not that easy to report, and so we thought, like everything, if there was an app you could report on your phone that you just answered a few questions. Now we were thinking to have that data go to FDA because that seems to be the receptacle, but the idea of having an independent organization, international, nonprofit and publicly available is very interesting idea. So we should definitely think about that, and I'd love to hear if others are interested or have ideas about it. The other things besides, and I agree with you, just telling patients is really not going to solve the problem. I do think, as I said, and I think was one of our solutions, I think both pre-market and post-market criteria for approval should be strengthened, because having this very kind of loose definition, which seems to be loose, of breakthrough devices, and then getting them onto the market and then not completing post-marketing studies just opens us up to a lot of uncertain devices that may actually be dangerous. And then we don't even know because we're not collecting adverse event data. You could have time-limited approvals. You could say if you're approved, if you're a breakthrough, your designation is good for a year unless you have actual clinical confirmatory data, and then just have it automatically have that approval go away without the clinical confirmatory data of safety and effectiveness. There was the idea about limiting prices. You could say no advertising because their direct-to-consumer advertising makes things so much worse. Kevin, did you have another idea?
Well, I just wanted to ask, building on Louise's comment, it feels like this is a disaster waiting to happen, right? You have this regulatory process, which has now been captured by the regulated, and where there are these very misleading signals where people think breakthrough, it means huge advance, it means careful scrutiny, and it doesn't, and then very limited post-market surveillance. So what I'm wondering is, are there disasters we just haven't heard about yet in terms of non-fatal adverse events happening in widespread fashion, or do you think that will happen and we just, the system hasn't quite caught up yet?
I think both. I think they're happening and that they will continue to happen. I think we hear about some of them, but not. Have you heard about the one that was in the papers last week was the Philips Respironics? The CPAP machines that have this foam that has evidently been causing serious respiratory problems for years, like 10, 12 years. And
wow,
there's been like some back and forth between the FDA and Philips, but nothing happened. Nothing, they sent a letter. Philips maybe didn't respond, did respond. Nothing happened and stayed on the market. And it finally, I think, got some press. And then remarkably, in the last month, Philips now reports 90,000 adverse events and 260 deaths associated with these CPAP machines that are still on the market. And not only that, there's no infrastructure to recall them. We still, even though it was mandated, I think, more than 10 years ago to have a unique device identifier on all devices, it hasn't happened. So there's no way to even contact patients that have them. The FDA hasn't mandated any kind of recall of these devices. Just before that, there was, one of a subcutaneous ICG lead, and there's only one kind of lead for this particular kind of ICG, was recalled from the market. The next week, I saw a patient who had just had one implanted. She had no idea that it had been recalled, so nobody told her about that in the consent process. I think it's happening all the time, but we're not hearing about it. We're not looking. And as I said, I think personally, it's the tip of the iceberg. It's not that deaths aren't occurring. We're just not hearing about them, not thinking about them, and therefore it kind of goes on with business as usual.
So we're actually out of time. So please join me in thanking Dr. Redberg for a great talk.